Hello guys, the topic of discussion today is going to be status epilepticus. So we'll be discussing briefly on status epilepticus and we'll be emphasizing more towards the management of status epilepticus. Let's get into the topic. So what is the definition of status epilepticus, which is very important because it has been changing from time to time. So this is the current definition, which says that continuous seizures or repetitive discrete seizures with impaired consciousness in the interictal period. So this is very important to know. This is easy definition, but if there is a seizure and there is a period in between another seizure, so this is the first episode and this is the second episode and this is the third episode, and between this first and second seizure we have a period called as post-ictal period, or in this case we may say, because there is a continuous repetitive seizures which are happening over here, we can say this as interictal period. Okay, this is interictal period. In this interictal period, if the patient is not gaining consciousness, or if the primary seizure, that the first episode itself is lasting for more than 5 minutes, we are going to say it as status epilepticus. So that is what is given here. Practically, if more than 5 minutes of continuous seizure activity is present, or a series of seizures without return to full consciousness in between the seizures, is called as status epilepticus. So we have a concept called as this time is brain in stroke. No, this also is applicable to this seizure. Why I will say? Because it is going to cause an array of abnormalities and complications which are going to be encountered in this patient if we are not going to treat the seizure on time. Okay, so types. What are the types? Generalized convulsive status epilepticus, non-convulsive status epilepticus. So what is this generalized convulsive status epilepticus? This is a acute emergency, guys, because generalized convulsive status epilepticus, it is easier to identify. At least it is a persistent seizure. There is going to be electrographic seizure. Okay, electrographically we can find the seizure over there. The patient is going to coma. Okay, the patient should be in coma actually, and there is persistent tonic-clonic movements will be present, which is very obvious, and it is going to make us identify the patient over here. And in non-convulsive status epilepticus, what is non-convulsive? The name itself gives away this is non-convulsive, because we are not going to have any outside manifestations like convulsions, fits. Okay, we are not going to have any of that. This is usually seen in this critically ill patients and intubated patients. But if the patient has absent seizures or focal seizures and it is lasting for more than 5 minutes, okay, or any minimal subtle movements, okay, subtle motor abnormalities can also come under this category called as non-convulsive status epilepticus. So this is very important to be borne in the mind. Okay, what are the causes? Causes are going to be this. First very important cause is the patient having the seizure for the first time, or he is a known epileptic. Okay, so if the patient is a known epileptic, a case of epilepsy, we should always take a history. Is he on anti-epileptic drugs, and is he taking the drugs continuously? So anti-epileptic drug non-compliance is going to be the first most important cause. Second one is going to be this alcohol. So alcohol induced seizures are usually due to thiamine deficiency in these patients, and supplementation of thiamine is must. Okay, and then acute structural brain injury. What are the acute structural brain injuries, or what can contribute to a structural brain injury acutely? That is RTA. Okay, if the patient has met with an RTA, or if the patient has a structural brain lesion like brain tumor, or if there is an abscess, or if there is a hemorrhage like SAH, or burst aneurysm causing SAH, or ischemic stroke, anything for that matter, it can lead to this acute structural brain injury that can cause status epilepticus. And metabolic abnormalities, this is going to be a wide array of metabolic abnormalities. The first one which we should keep in mind is this hypoglycemia. So any patient with seizure, after stabilizing this airway, breathing and circulation, we are going to check glucose. So hypoglycemia should be borne in mind. And there was a question whether hypoglycemia causes seizure or hyperglycemia causes seizures. So keep in mind that both hyper and hypoglycemia can cause status epilepticus, and it can cause seizure. Okay, so this hypocalcemia and hypomagnesemia should also be kept in mind. Pyridoxine deficiency is a cause of refractory status epilepticus in children most commonly, and uremia and hyperammonemia, like any liver disease, hepatic encephalopathy, can cause metabolic abnormalities. And overdose of drugs. Overdose with drugs, mainly fluoroquinolone, should be borne in mind. And this imipenem and cilastatin is a drug which is been tested enormous number of times in the INICET and NEET PG exams. They are going to lower the seizure threshold and cause seizures, okay? And it can also cause status epilepticus, obviously. So we have come with a case scenario, a simple one rather. A 45-year-old patient presented with convulsions, 3 episodes en route to the hospital. So simple பார்த்தீங்கன்னா ஒரு 45 வயசு இருக்கவர் 3 எபிசோட்ஸ் வந்துருச்சு அவருக்கு சீஷர் ஹாஸ்பிட்டலுக்கு வர வழியிலேயே. Each episode lasted around 5 minutes. ஒன்று 5 minutes இருக்கு and he is unconscious. Okay, so the patient's GCS is E1, V2 and M4. On arrival, he started convulsing again. So what we are going to do now? We are the emergency medical officer there. So இப்போ நம்ம என்ன பண்ண போகிறோம் அப்படிங்கிறது தான். So any emergency, the first thing which should come to our mind is going to be this airway, breathing and circulation. So first 5 minutes are golden minutes over here, because whatever the diagnosis which we are going to arrive at the later part, it is going to be depend upon this first 5 minutes. So first check the ABCs, check airway, breathing and circulation. Say if the airway is not patent, or if the patient has an irregular type of breathing. So what is that? Very importantly, if the airway is not patent, the patient could be in a hypoxic or anoxic state, and this could be the cause of the status epilepticus or the continuous seizure which is getting. Breathing, if the patient, if you find he is having a Kussmaul's pattern, okay, Kussmaul's breathing pattern, what we can suggest is the patient is acidotic or a case of DKA probably. Okay, and circulation is very important to be ruled out. If the patient is pale, if the patient is not getting enough blood to the brain, it can also produce hypoxia, correct? And it can produce anoxia and it can produce seizures. Okay, so airway, breathing and circulation must be maintained. If the patient is having a shock can provoke seizures. Okay, shock should be treated. So shock can provoke seizures by impairing blood supply to the brain. So all these should be borne in the mind. Check ABCs, check mainly if anything lies in these, the cause lies within this ABC, and if you are not correcting it, whatever we are going to do further is not going to be a matter. Give O to the patient, because whenever there is a seizure, there is a trend. Okay, there is a trend that the patient is going to have airway compromise anyways. So this seizure, if it is a generalized convulsive status epilepticus, it is going to be a violent movement, and the patient can have aspiration also. Okay, aspiration could be due to anything. Mostly patient will have tongue bite, and in any seizure episode the patient is going to have tongue bite, and there is going to be involuntary voiding of urine and feces. But anyways, the patient is going to have aspiration, so check that correctly. And obtain 2 large bore IV access. This is very important. If we can't get an IV access, what we can do, I'll say it later. Okay, so begin ECG monitoring also. So it could be due to an arrhythmia which has thrown a clot and it is blocking, or it is blocking the blood flow to the brain, or any ECG for any ECG abnormality which is caught. Okay, so that is very important. Begin ECG monitoring. Next, as I have said, this is very, very important, guys. We must check the capillary blood glucose of this patient. And then serum electrolytes, mainly serum calcium and serum magnesium is very important, and send for all the routine investigations like RBF, RFT, CBC must be taken in this patient's RBF, RFT, serum electrolytes. And we can also send for a toxicology panel. And in routine investigation, if the patient is a known case of seizure disorder and he is having the he has been on anti-epileptic drugs, we can check AED levels also. Okay, so first 5 minutes is over now. Next 5 minutes la enna panna porom, impending and early status epilepticus, that is 5 to 30 minutes. First next 5 to 30 minutes is said to be impending or early status epilepticus. So what is the drug of choice for status epilepticus is the most commonly asked question in all the exams, that is going to be lorazepam. Why lorazepam? Lorazepam is chosen because the onset of action is very quick, first point. Second thing is benzodiazepines have relatively lesser side effects, and there is an antidote also. So flumazenil is there, so there is an antidote also if there is a case of overdose. So lorazepam. Why lorazepam? That too, if a patient is uremic and it is the patient's renal clearance is very, very low, we can use lorazepam because it is not renally cleared. So lorazepam is very important. Okay, next is midazolam and next is clonazepam. So all these 3 can be given, but IV benzodiazepine is the first line. Okay, next after that also the patient is continue to seizing. Okay, patient is continuously seizing. Next we can take this IV anti-seizure drug, anything like phenytoin 20 mg per kg, valproic acid 20 to 30 mg per kg, or levetiracetam 20 to 30 mg per kg. This is very important to note. Okay, so Now, generalized convulsive or subtle status epilepticus is present, or focal complex myoclonic or absence seizure is present. What we are going to do? Already we have discussed extensively about this, established, and next 30 minutes to 48 hours is going to be established and early refractory status epilepticus. In this, what we are going to do is we are going to give IV midazolam. First, we are going to give a 0.2 mg per kg if the patient is continuously seizing after giving an IV anti-seizure drug also. So IV midazolam 0.2 mg per kg should be given, and it should be converted to an infusion. Okay, 0.2 to 0.6 mg per kg per hour. And we can give IV propofol, which is 2 mg per kg, and it should also be converted to an infusion 2 to 10 mg per kg per hour. And if the patient is having a focal complex or focal complex seizure or myoclonic or absence status epilepticus, in that case we are going to give valproic acid, levetiracetam, topiramate, and there is a wide range of drugs for that. Okay, next, even then the patient is seizing, okay, even then the seizure is not controlled, then we are going to settle the brain now. So by giving this pentobarbital or thiopentone sodium, in which we are going to give 5 mg per kg or 1 mg per kg must be starting dose. Okay, 5 mg per kg, and it should be converted to infusion of 1 to 5 mg per kg per hour. This is the barbiturate coma. The patient is in comatose state now. Okay, and even then the patient is seizing. Okay, even then there is seizure which cannot be controlled in this patient. We are going to give other medications like lidocaine, verapamil, magnesium, ketogenic diet, immunomodulation, or other anesthetics can be tried like isoflurane, desflurane, ketamine can be tried. Other approaches can also be tried like surgery, ECT, RTMS, RNS, VNS, and vagal nerve stimulation is also a very important modality now, and hypothermia must be checked. Okay, so this is in brief the management of the seizure. Okay, in brief in the management of status epilepticus. Okay, next, whatever happens, take an EEG while following up. So why are we treating this status epilepticus aggressively? To put a patient in coma, is that much injuring to the patient, as it can cause very much medical complications that can threaten the life of the patient. First thing is it can cause like altered auto-regulation, and there is increased cerebral blood flow, there is cardiac arrest which can occur, there is a cardiac arrest which can occur during seizure, can cause hypertension, and it can cause cardiac failure, and the patient can go to cardiogenic shock even. Okay, so this is very important. And then in respiratory system, respiratory failure the patient can go, because as we said there is a risk of aspiration and pneumonia to this patient, that one. So always look for Cheyne-Stokes breathing in this patient. Okay, and look for cyanosis also. This is very important. And then in renal complications, the patient can go for acute tubular necrosis and rhabdomyolysis also. Okay, and there is also going to be autonomic imbalance, and at last, very important thing which is very important is the patient ultimately can go to multi-organ dysfunction, and which some questions which are asked is it associated with fracture? Yes, it is associated with shoulder dislocations also. So all these things should be borne in mind. So remember this protocol, and it will be tested in exam surely. So this is a brief, very brief discussion about how to manage status epilepticus in an emergency setting. Okay, so after that after the patient has been stabilized, we have to wean the patient, and if the patient is in ventilator per se, and we have to wean the patient, and after weaning we should put the patient for a course of IV anti-epileptics, and then we can switch over to oral anti-epileptics and follow up. Okay, so a summary. So if the presentation is going to be seizure lasting more than 5 minutes or multiple seizures within 5 minutes without return to baseline, and the critical presentation is going to be seizures associated with CNS infections, okay, we must administer antimicrobials without delay. That is very important. Okay, and there is a role of steroids in those patients also, because with the administration of antimicrobials, particularly in the case of a neurocystic we must remember that. So in that, if we administer only the antiparasitic drugs, the patient is going to land up in the neural tissue is going to be damaged so much, and there is a risk of anaphylaxis also in that patient. So we must give steroids in that patient also. So steroid giving is also a part. Okay, next, how will you diagnose? An immediate bedside glucose and ECG is very important. Consider HCG to rule out the structural cause, the third cause which I have said, and consider LP if there is an infectious etiology is suspected. Lab work must contain toxicology, AD levels, and CMP levels also, CK levels also, and urine pregnancy test must be done in these patients. See, that should be borne in mind always. If it is a reproductive age female, urine pregnancy test should be done in those patients. Okay. Okay, next is management. Airway management and hemodynamic monitoring is very, very important. In rapid sequence intubation, consider propofol for induction. So there is something called as rapid sequence intubation, and in that we must consider propofol for induction, and we should continue it as a drip. So it is that side, it is safer. So in that way we can use a single drug. Okay, so that is very important. Next, benzodiazepine administration. Remember, lorazepam is the drug of choice, and in second line anti-epileptics or levetiracetam, valproic acid, phosphenitoin, and phenytoin. Nowadays we are using levetiracetam left and right because with even only levetiracetam, the status epilepticus is managed very well. And address underlying cause like infectious agent. If there is hyponatremia, treat the hyponatremia, and remember always central pontine demyelination must be kept in mind in treatment of hyponatremia. And eclampsia is a whole other story. If the patient has eclampsia, we are going to follow Pritchard regimen for max sulfate infusion. So that is also very important. And next is there are n number of regimens, Pritchard, Zuspan, and we should keep that in mind also. And monitor for hyperthermia and hyperkalemia and rhabdomyolysis and acute kidney injury. This is very important. Always look out on the urine output of the patient. In sudden deterioration, consider airway compromise, sepsis, and recurrent seizure activity. Mostly all these patients who have seizure, they cannot maintain the airway, so they are going to succumb to something called as aspiration pneumonitis. That is the most common cause, okay, of mortality. Even the brain structural cause is going to predominate this, not going to predominate this, because this aspiration pneumonitis is going to be a major cause in these patients, and they are going to succumb to aspiration pneumonitis and respiratory failure later on. So it is very, very important to check for that also. Antibiotics are going to play a role. Anti-edema measures are also going to play a role if there is a structural cause, and if the patient has epileptic syndrome, which anti-epileptic you are going to choose is also going to play a role. With that, we have come to the conclusion of this model. Thank you so much.